Bushra, we have.
Sure. Assalamu alaikum. My name is Kiran Amir and I'm Director of Operations at PSH ECHO Pakistan, the Super Hub. I would like to welcome you all to yet another session in the series of Hepatitis ECHO, and it's in collaboration with Pakistan Society of Hepatology. Today's session is case-based discussion with experts, and our expert for tonight is Dr. Bushra Ali. Before I introduce you to the expert for tonight, we would like to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in the session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation. So you can unmute yourself for questions and use the raised hand option or chat box. By participating, you have given the consent for recording. The recorded session will be available on our YouTube channel and link will be shared in the chat box. For CME credits, please contact Uzair, our coordinator. His number is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. For the convenience of the folks, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. Our expert for tonight's session is Dr. Bushra Ali. She is currently serving as Hepatitis ECHO Lead Punjab at PSH ECHO Pakistan. She has more than 9 years of experience post-fellowship in internal medicine and over 3 years post-fellowship at gastroenterology hepatology. She continues to build up her skills and knowledge base regarding patient care, recent advances in medicines and endoscopic procedure, and tries to demonopolize the knowledge via hepatitis tele-echo sessions. Her core responsibility at PSH ECHO Pakistan are tele-echo session monitoring, feedback evaluation, research related to tele-echo clinics. She is also responsible for meta-echo submission on behalf of PSH ECHO Pakistan. We have 2 cases today, and Dr. Masooma will be presenting the cases. So I will hand over to Dr. Masooma. Dr. Masooma.
Assalamu alaikum, everyone.
Wa alaikum salam, Masooma. We can hear you. Uzair, isko thoda sa, if you can zoom in, isko thoda sa bada kar dein iske fonts ko. Yes. Ji Masooma, please go ahead.
So the first case is a 61 years male ex-smoker presented with postprandial fullness, swollen feet for 2 years, epistaxis off and on for 1 year, history of weight loss of up to 10 kgs over 1 year. On examination, pallor, there is no pallor, there is pitting edema, abdomen is soft and chest is clear. CTP score is A6. The first investigations show HB is 14, serum creat is 0.65, platelet count is 153, bilirubin is 1.7, ALT shows 143, AST is 170, and PT-INR is 1.42, PT is 15.5, and INR is 1.42, AFP shows 117.6. On ultrasound scan dated 26/22, chronic liver parenchymal disease with hepatic space occupying lesion in right lobe of the liver. It is most likely HCC, bilateral renal calculi, gallbladder polyp is shown, and simple left renal cyst, and enlarged prostate. CT summary, atypical 21 mm HCC in segment 6, no further nodules in this cirrhotic macronodular liver. Portal and hepatic venous system is patent, mild splenomegaly, minimal varices, and no ascites, no lymphadenopathy. Lung bases are clear, and no focal osseous abnormalities found. The questions are, should we proceed with treatment? How should we proceed with treatment? Should we start AVT or should we treat HCC first?
Assalamu alaikum. Thank you, Masooma. Just a little bit of clarification. आप देखेंगे इंग्लिश कितनी कंफ्यूजिंग है. जो CT summary है इसमें लिखा हुआ है atypical. It is not atypical, it is a typical 21 millimeter. It's a typical 21 millimeter lesion. So it was an SCC. Typical का मतलब है कि इसमें arterialization है with portal venous washout, जो कि portal venous phase में हम देखते हैं. So that was a typical around 2 centimeter lesion. So this gentleman presented for the first time. Is a treatment naive case, ex-smoker with swelling of feet, and during the course of investigation, when he was being worked up for treatment of hepatitis C, alpha fetoprotein was raised, and ultrasound also showed a space occupying lesion, and we have a 21 millimeter segment 6 lesion consistent with HCC. There is no vaso-invasion, ascites नहीं थी, minimal varices हैं on CT scan. So Bushra, there are two questions. किसको पहले पकड़ें या इकट्ठा पकड़ें? So what do you think?
I think we should get rid of the HCC first. It is typical, and the patient, it's quite small enough to be treated by a curative method instead of a palliative method. So yes, we handle the HCC first. The antiviral treatment can be delayed. Abhi to A6 hai na, so probably this lesion is amenable to microwave ablation. Dr. Najam hai, unse pooch lete hain. Would he like to do it?
Bushra, I agree. 21 millimeters would be a good lesion to microwave, especially segment 6 lesion, central lesion, so it shouldn't be a problem. Sorry, miss kar gaya, I've just got in. So Billy 1.7 hai, हमारा CPT क्या आ रहा है?
A6 है ना? जी.
और INR भी जो है हमारा कितना है 1.42. So INR would be a problem here. 1.42. That's the catch. So ये अभी बड़ा issue चल रहा है. In fact, if I may ask this question, अभी एक दो pipeline में भी ऐसे patients हैं. इनका INR किसी तरीके से medically आप लोग बेहतर कर सकते हैं?
जी फारूक, I would like to get you in. आप कितने comfortable या uncomfortable हैं for any procedure at 1.4?
अच्छा, we are very comfortable with 1.5. We do even cis gastrostomies at 1.5. So it's not really that dangerous from our perspective. लेकिन of course आप लोगों को जिनको percutaneous जाना होता है, I'm assuming कि आप लोगों का IR का ये different वो होगा. Can we reverse this? अच्छा, मैं थोड़ी सी ना आपको attention draw करता हूँ कि not necessarily जो serotics होते हैं उनमें INR की abnormality is not down to just very poor synthetic liver function, particularly if the socio economic background isn't terribly level 1 or level 2, तो ये malnutrition driven भी होता है. So I don't necessarily think it's unreasonable to give these patients vitamin K, and we've actually seen that vitamin K in its own rights will actually get or correct their INR, certainly to an extent which is acceptable to all parties for the intervention. अच्छा, अगर यही patient मेरे पास, so we sometimes do get referrals from outside. और जब वो पेशेंट लैंड कर जाता है आपके पास उसकी सिस्ट ड्रेन करने के लिए या मेटल स्टेंटिंग के लिए, तो आपको पता लगता है उसका INR 1.6 1.7 है. So we don't send that patient away. What we basically do, we give them a bag of an FFP about hardly an hour, maybe a couple of hours before the procedure, and then we do the procedure with another FFP bag ready at hand. Should we need to give if there is a serious problem with the bleeding? अगर मुझे प्रोसीजर में ही पता लग गया कि यार इसकी तो ठीक ठाक ब्लीडिंग हो रही है जो नहीं रुक रही. दूसरा जो INR liver disease का INR होता है, that's not necessarily reflecting the thinness of the blood. It doesn't mean कि इसके पेशेंट के ब्लीड करने के चांसेस बहुत ज्यादा हैं. Not necessarily, क्योंकि जो liver disease की coagulation है ना, that's very complex. So I think in this patient particularly, Dr. Najam, I don't know आपका threshold क्या है for IR, but if you really want it below 1.4, I think just vitamin K 10 milligram IV a night before the procedure. I don't think it will be too difficult. But again, I actually don't know कि आपका threshold क्या है.
मेरा फारूक 1.4 ही है actually. When we repeat INRs when the patient come in just before the procedure, और वो हमेशा different निकलता है. Most of the time, it is better than 1.42. और ये काफी दफा हो चुका है वहाँ साहब. एक आधे केस में when we had a larger lesion to ablate, which was peripheral subcapsular, उसमें हमें जरा प्रॉब्लम हुई है because we knew that he would bleed. हमारे पास इतना normal parenchyma का tissue नहीं होता between the capsule and the lesion जिसको हम ablate करके आए हैं, और खासकर if we are going through a patch of portal segment. So वो channel जो है वो somehow when we are ablating our pathway वो mature सा हो जाता है, and you know portal system then bleeds in the capsule or in the vicinity of perihepatic. So I agree with you. I've not seen many patients improve with vitamin K, even if we use it repeatedly for a long period of time. So I absolutely agree that vitamin K has not helped us at all in these patients. Or microwave हम अब काफी frequently कर रहे हैं, and we prefer that, given that it falls in the curative part of the treatment, equal to surgical resection, if not at par, slightly close to it, depending के patient कैसा है.
आप RFA offer करते हो?
I moved on from RFA for quite some time now because
अच्छा.
I'm very trigger happy with microwave, and especially with one particular vendor. क्योंकि जो एक प्रॉब्लम थी ना कि आपने peripherals को नहीं छेड़ना, exophatic को नहीं छेड़ना और इनको नहीं छेड़ना, ये they tend to bleed या complications का rate high होता है. Alhamdulillah, well, touch wood, I'm doing, and I'm sure my colleagues will vouch for it, I'm doing most of the atypical lesions in very odd positions. And Alhamdulillah, वो experience और एक courage होता है ना इंसान का,
हाँ, true.
वो build up हो गया है कि you touch those lesions which others won't even think of touching. So at the dome, segment 8 lesions, the lesions next to the IVC portal system, अभी जो आज की है मैंने, that's right in the crouch of the portal system, दोनों bifurcation के and top पड़ा हुआ है, so and so forth. So point ये है कि it's better to play safe. मेरी एक और problem है. I work in a diagnostic center standalone. I do not have the hospital backup as per se one would want. लेकिन अगर कुछ करना भी हो, even though if I have the arrangements, I would want to be more careful than people who are working in a hospital setting. ये मेरा difference, and that's why I take a high risk consent as well if I'm working around 1.4, and I also get cover of the plasma FFPs.
True.
Thank you. Bushra, जो अगला question है, हमने इसका we have decided कि we are going to ablate the lesion. हमने microwave किया, और 4 weeks down the road we repeat a CT scan, and let's assume कि INR जो है इसका around 60-70 है, or lesion looks good on CT. Dr. Najam is happy that he has done a good job. So what about treatment, antiviral treatment? Where would you fit in for this patient?
ये तो अभी mention हुआ है ना कि microwave ablation is close to cure of the disease. So अगर cure हो जाता है and Dr. Najam is happy with the results of the microwave ablation, then we treat the virus, definitely so. Direct acting antivirals, fosfovir and velpatasvir ka combination, and I would combine it with ribavirin because he has evidence of portal hypertension also. He has started to decompensate.
That will be the time when we have seen a response through intervention. फारूक, आप इसमें कोई आपका कोई पर्सनल एक्सपीरियंस दीस पेशेंट? हेपेटाइटिस बी में तो हम जल्दी शुरू कर देते हैं और बाकी चीजें भी देखते हैं, तो हम सी में वो पॉलिसी क्यों नहीं लेते? आई एम टॉकिंग अबाउट अ गुड रिस्क केस लाइक दिस इज, जिसमें वी हैव अ क्यूरेटिव ऑप्शन।
बिकॉज हेपेटाइटिस बी के ट्रीटमेंट का जो है ना वो the risk and the studies have not really shown a major risks or high risk for in fact generating a HCC. Number one. Number two, hepatitis B, the virus itself is oncogenic, and that is the difference between the treatment of hepatitis B and hepatitis C. We have even seen patients recompensating from decompensating on hepatitis B treatment. So that's why we have become slightly more not careless but more confident, if the word, about hepatitis B. With hepatitis C, yes, we are. So I think with this patient, this is entirely reasonable. You do the treatment, you repeat the CT in 4 weeks, and if the lesion looks all very clear, then I think it's very reasonable to actually offer this gentleman a treatment. Is there a cool off period? Some people say yes, you should wait for at least 4 to 6 weeks. But really, one way or the other, this man would need a treatment. I may ultrasound him right after the treatment, and I may really ultrasound him during the treatment as well. But that's as far as really. I don't think we should not treat him.
मैं एक चीज अगर परमिशन हो ऐड कर दूं, हमारे जो protocol है for assessment after the procedure, at the end of the procedure, I tend to do a formal CT scan there and then. And the reason for doing that immediate scan after the intervention is to be absolutely certain that I've completely ablated the lesion. So हमें उसी वक्त पता लग जाता है. So the question, cooling off time का जो है starts from right after we've done the ablation. अगर नहीं हुआ हुआ और ablation में unfortunately अगर मैं pick कर लूँ कि margin रह गया या फिर I'm short या misdirected, I would go back in and do it again till it's all completely ablated. So I do not leave it to the next session or a add-on टेस्ट प्रोसीजर. अब इसके ऊपर भी आर्गुमेंट है, अब जो चेंज आ रहा है और काफी स्ट्रांगली बिल्टअप हो रहा है अक्रॉस द ग्लोब इनफैक्ट, कि क्या कॉम्बिनेशन में करने का कोई फायदा है, बोथ एंडोवास्कुलर एंड परक्यूटेनियस एब्लेशन प्रोसीजर्स डू बेटर, या कहीं पे हो रहा है यूके में फॉर दैट मैटर? मुझे ये तो पता है यूएस में हो रहा है, काफी जगहों पे हो रहा है.
नहीं, यूके में ऐसी अभी कोई स्टडीज नहीं है दैट दे विल ऑफर microwave as well as taste together.
So I would add that we need to one, find out his hepatitis B status, vaccinate against hepatitis B. 2, he needs a surveillance endoscopy. 3, he should ideally be vaccinated against hepatitis E also, since he has cirrhosis and we want to prevent acute and chronic hepatitis in his case. This goes hand in hand with the antiviral treatment.
Very good points.
Ji. Thank you, Bushra. Uzair, if you can stop share and we can take any questions on this case from the audience. And anybody with a question, Dr. Najam is here, Farooq is here, Dr. Bushra is here. इस केस से रिलेटेड कोई भी सवाल अगर आपके ज़हन में है?
मैं करूं क्वेश्चन और while we are getting more people to get engaged, as soon as we do microwaves, at least in our experience, we found anecdotal care, I don't know, I'm actually looking for evidence, क्या इन लोगों का जो decompensation है या liver synthetic profile है वो improve करता है? We find that it improves somehow or other. How does it work? I don't know. You shine light on this thing. Treatment के बाद.
मेरे ख्याल में it has more to do with taking away the cancer, even with the patients who undergo TACE or TAE, I mean, I've seen people, I mean, I think amongst ourselves, we have a lot of experience. We have seen some decompensation, acute decompensation, but when they settle down and they come up, they pull through, then I think they do better if the cancer is taken care of in a better way. Of course, this RFA or microwave is a curative option, and that's why we were very keen for hepatitis C antiviral treatment कि हम virus को भी equation से out कर दें, क्योंकि these drugs are wonder drugs and they just kill the virus and bring the viral load down like anything. जी, आप कुछ कहना चाहेंगे बुशरा फारूक?
जी, जो हमने पेपर भी पब्लिश किया था जिसमें क्वालिटी ऑफ लाइफ जो है वो सब्सटैंशियली इम्प्रूव कर जाती है once you get rid of the virus, especially in child class A serotic patients. So yes, if you get rid of the HCC first and then you treat the virus, the quality of life certainly improves, because that viremia that causes the generalized aches and pains and the low feverish state in patients, that tends to go away. A6 is ideal for treatment for hepatitis C.
Bushra, while we go to the next case, there's a question in the chat from Dr. Nadia. She wants to know why. ये वैसे आपका पेट सब्जेक्ट है तो आपको प्रॉब्लम नहीं होनी चाहिए, इसलिए मैं किसी और से नहीं पूछूंगा कि आपका एक्सपर्टीज है इसके अंदर. उन्होंने भी इसलिए ये सवाल डाला है. She wants to know why LFT are deranged in pregnant ladies and having symptoms of itching. Why this is common after 25 weeks of gestation, I think. Gestational amenorrhea mostly. जी.
So basically, Nadia, what happens in pregnancy is that the bilirubin, the ALT, AST is supposed to stay normal. Alkaline phosphatase rises in the third trimester, but only marginally. The albumin is physiologically low during pregnancy. Itching in the third trimester of gestational amenorrhea means that the patient is suffering probably from intrahepatic cholestasis of pregnancy. And in that case, the ALT and AST will rise and the alk phos will jump. But although we think that this alk phos is originating from the liver, the gamma GT tends to remain normal despite the alk phos being generated by the liver. So although the understanding is that gamma GT will follow ALP, but it doesn't happen in this case. The thing is that if you want to find out why this patient has itching, the first thing is that this itching is going to be typically originating from the palms and soles and will spread to the extremities. 2, the patient will not have any rash or lesions on the body apart from the marks of excoriation if she's been itching very badly. 3, she will have a family history of itching during pregnancy. Her mother, her elder sister, maybe her khala will report this. She will herself say that she has had itching in her previous pregnancies, if this is not the first one, if she's not a primary gravida. So you ask how many children she has had previously and what kind of history there was. And she will give a positive history of itching while using oral contraceptive pills. So if the albumin is isolated, is the only thing that is deranged, that is low during pregnancy, it's physiological. If ALT and AST are raised, it definitely has to be investigated. If the alk phos is raised, the patient has itching. This is intrahepatic cholestasis of pregnancy, but you do not see a raised bilirubin in intrahepatic cholestasis of pregnancy. If the bilirubin is raised, get an ultrasound done. I usually get it done in all my patients who present with itching. Get a look at the biliary tree, because in pregnancy, the gallbladder tends to have stasis of bile and tends to form more stones and sludge than normal. And it tends to cause obstruction as well. So the patient might be suffering from cholangitis that will also produce a raised alkaline phosphatase, but would also give a raised bilirubin. So that is the top of the list in the differential. The third thing that we over here and for this entire week, we've been seeing very commonly is cholestatic phase of acute hepatitis E and A. So the patient will have an ALT of maybe 500, which usually does not happen with intrahepatic cholestasis. And you get hepatitis E done because she has a history of mild epigastric pain and vomiting, and it turns out to be positive. So that also needs to be ruled out. That comes with maybe you look at the ALT very closely and take a very detailed history. Have you had nausea recently? Anorexia, vomiting? Did you have epigastric pain? Because these things don't happen with IHCP. So, Nadia, does that answer your question?
जी फारूक आप कुछ ऐड करना चाहते हैं? Then we move on to the next.
Hey, I want to utilize the expert really. So, would there ever be a point that we become so concerned about IHC that we deliver the baby sooner than it should be? Number one. What are the LFTs where you would be classically start to worry that it is not IHC and may well be AFLP?
No. So you see, fatty liver of pregnancy has an acute presentation. The patient will not come and say that she has itching. Her relatives will be bringing her in with acute liver failure. So that is something that has a completely different presentation and outcome as well. But what you are saying is, what you're saying about the early delivery is that the ACG guidelines state that you deliver at 37 weeks because cholestasis is associated with IUGR, with IUD and stillbirth. So what my gynecology colleagues do is that they provide them with steroid cover and they induce labor or conduct C-section at 37 weeks of delivery, of gestation. Now, what happens in some cases is we've had premature rupture of membranes as a result of cholestasis. We've had patients who had rebound itching. So they were going fine on also deoxycholic acid. The alphos was coming down, the bile acid level was coming down. But all of a sudden, the labs start rising again. The patient starts complaining of itching. That's bad prognosis. And when you get the bile acid levels done, if it is more than 40, that's also bad prognosis. So you delay, even if the patient is at less than 37. We don't go beyond 37 in our patients.
Thank you.
And any levels of alkaline phosphatase where you would say, yeah, that is definitely not pregnancy. This is IHC, with or without itching.
The interesting thing is that alkaline phosphatase has to be raised with itching. If the patient is saying, I have itching, and her ALP is not raised, she does not have obstetric cholestasis. So I send her to the dermatologist.
Fine, great, thank you.
Thank you. Thank you, Bushra. Uzair, you can start sharing the next case. और बुशरा अब आप एक साल बाद आई हैं तो आपको जुर्माना अदा करना पड़ेगा.
साल बाद आई हूं मैं.
We really miss you. आप आज इतना अच्छा पढ़ाती हैं कि ये काम तो ठीक नहीं है. तो
ना शर्मिंदा करें डॉक्टर सर.
Engage you more often. इसको थोड़ा सा zoom कर दें उजायर, थोड़ा सा. जी डॉक्टर मासूमा, please go ahead if you are to present this case.
Yes, sir. The next case is a 30-year female presented with generalized weakness and her surface antigen for hepatitis B virus is positive for 5 years. She recently had ischemic heart disease and DNC at 8 months of pregnancy. No other comorbidity. She is very concerned about her intrauterine fetal death and DNC. She thinks it happened due to her HBs-AG positive and also wants to know about risk of vertical transmission of hepatitis B virus to her next babies. On examination, nothing abnormal is detectable. Investigations show hemoglobin is 10.5, platelet count is 289, and anti-HCV is negative and surface antigen for hepatitis B is positive. Ultrasound abdomen is not available. The questions arise, what further investigations will be required before starting the treatment and how to counsel this patient?
Thank you, Masuma. मुझे सिर्फ I have not seen the file, but ischemic heart disease मुझे कोई हजम नहीं हो रही at 30 years of age. I don't know.
ये ischemic heart disease है कि ये IUD है? IUD में
मेरे ख्याल
DIC
this is
करते
IUD.
IUD.
IUD actually.
Intrauterine.
करते हैं ना मासूमा?
ये IUD है, ये ischemic heart
अच्छा.
disease.
I think it's a typo. Yeah.
Probably she must have had an evacuation 8th month of pregnancy पे, तो dilatation and curettage तो मुश्किल है, लेकिन खैर ये चलें, let's assume
Bushra,
that
ये
she
बड़ा
had an
common
intrauterine death.
scenario है, तो जो main
बहुत,
issue है वो ये है कि how we are going to go about this, what next in next pregnancies, क्योंकि ये बहुत ज़्यादा family के लिए और उनके लिए बड़ा traumatic है, तो that's what we really need to discuss. जी Bushra.
So the only thing that we know is the surface antigen status. We don't even know her liver function tests. So मैं अब बोलना शुरू कर देती हूँ जो investigations होनी चाहिए. So 1, ideally hepatitis B surface antigen levels हो जाने चाहिए architect method से. 2, HBV DNA quantify करें. E antigen status, anti-HBE status, hepatitis D status. If anti-HDV is positive, get her HDV RNA, done. वो खान करते हैं. Plus, you get, since she's not pregnant at the moment, you get her alpha-fetoprotein done. Hepatitis B can cause HCC even in a non-cirrhotic patient. Plus, an ultrasound abdomen. And if possible, non-invasive method से करना ही करना. So, इसके अलावा, I always write it down on the prescription. तमाम खानदान के अफराद हेपेटाइटिस बी सर्फेस एंटीजन चेक करवाएं और नेगेटिव होने की सूरत में हिफाजती टीके लगाएं. मतलब कि मैं ये भी लिख देती हूँ कि वो लगवाने के लिए मेरे पास आए, ये भी कभी कभी कहते हैं. So, अब रिजल्ट का ये है कि काउंसलिंग इस तरह से होगी कि लिवर फंक्शन टेस्ट्स, अभी तो ये नॉन प्रेग्नेंट स्टेटस है, अभी तो हमने ये देखना है, इज शी अ कैंडिडेट फॉर ट्रीटमेंट और नॉट. Does she have a antigen negative disease or positive disease? Is she a candidate for treatment or not? Third, let's say she is a candidate for treatment. See, scenario A में चले जाते. Since she wants to have a baby, she should not be started on entecavir or lamivudine. She is a candidate for tenofovir disoproxil fumarate. अभी तक pregnant women में approve नहीं हुई, लेकिन जो latest news आती है वो यही है कि it hasn't shown any adverse effects. But अभी हम फिलहाल तो TDF ही इस्तेमाल करें in pregnant women or in women who want to conceive, childbearing age. Let's say the E antigen status is positive. फिर तो वो ही जो गाइडलाइंस हेपेटाइटिस बी की कहती हैं कि आपको ट्रीट करना है और फॉलो करना है. अब ये पेशेंट है 30 इयर्स का. अब अगर गाइडलाइंस जो हैं अगर आप उनको पढ़ें तो वो तो स्ट्रेस ये भी करते हैं कि आप इनको पेगुलेटेड इंटरफेरॉन यंगर एज में दें ताकि सस्टेन्ड वायरोलॉजिकल रिस्पॉन्स का कोई अच्छे चांसेस बन जाएं. लेकिन मेरा एक्सपीरियंस पाकिस्तानी पॉपुलेशन में ये है, दे हैव सच फियर ऑफ इंटरफेरॉन that this patient will refuse to get any kind of treatment. मैं ऑफर जरूर कर देती हूँ क्योंकि वो finite duration है, 1 साल के लिए है. If she can practice contraception for that 1 year, pegylated interferon. अगर नहीं तो childbearing age को रखते हुए नजर में इनको tenofovir disoproxil fumarate शुरू कर दी जाएगी. Now this was scenario A in which the patient is a candidate for treatment. अब let's say this patient was not a candidate for treatment, but she wants to conceive. आपके पास viral load होना चाहिए before you allow her to have a baby. But again, you repeat that viral load at the 7th month, यानी 20 to 28 कहते हैं, 26 to 28 sorry कहते हैं, तो 26 weeks पे आप viral load repeat कर लें. In E antigen positive patients, regardless of the ALT, 200,000 से ज़्यादा hepatitis B viral load, you treat the patient. This is not a candidate for treatment. We are trying to prevent mother-to-child transmission, MTCT for short, जिसको कहते हैं. So last 3 months में pregnancy के tenofovir disoproxil fumarate मिलेगी. Then 12 weeks afterwards भी मिलेगी. And you then keep the patient keep monitoring the patient for a flare after you have stopped it 12 weeks after delivery. मदर टू चाइल्ड ट्रांसमिशन को प्रिवेंट करने के लिए जो दूसरा है जरूरी चीज वो ये है कि आपने पेशेंट को दे दी न्यूक्लियोटाइड एनालॉग, लेकिन आपने बेबी को विद इन 12 आवर्स ऑफ बर्थ HBIG लगाना है, यानी हेपेटाइटिस बी इम्यूनोग्लोबुलिन, एंड वैक्सीनेशन की फर्स्ट डोज लग जानी चाहिए. तो हेपेटाइटिस बी इम्यूनोग्लोबुलिन की जो डोज है वो है 0.5 ml. बच्चों में इंट्रामस्कुलर लगता है थाई पे, तो एक ही जगह नहीं लगानी. राइट लेग पे लेट्स से इम्यूनोग्लोबुलिन लगा दें, लेफ्ट लेग पे फर्स्ट डोज ऑफ वैक्सीन लगा दें. Children born to hepatitis B positive mothers, they need to have a regimen that is shorter. एक एक्स्ट्रा डोज है और शॉर्टर है. वो है हमारा तो है ना 016, इनका होता है 0136. एक और रेजिमेंट है जिसमें वो देते हैं 0, 1, 3 and 12. तो ये WHO की गाइडलाइंस में मिलता है. तो ये है कैंडिडेट नॉट फॉर ट्रीटमेंट और कैंडिडेट फॉर ट्रीटमेंट में डिवाइड कर लें, एंड देन यू काउंसल द पेशेंट अकॉर्डिंगली. Tenofovir is known to prevent mother-to-child transmission and brings it down to 0%. जो trials में. Breastfeeding, yes, you allow the patient to breastfeed regardless of whether she's being treated or not. Tenofovir is not a contraindication to breastfeeding. So counseling में counseling बहुत ज़्यादा results के ऊपर भी depend करती है, लेकिन यही है बेबी की ट्रांसमिशन को प्रिवेंट करने के लिए दवाई देंगे और बेबी को HPEG एंड वैक्सीनेशन करेंगे. एक और चीज, इफ द पेशेंट टर्न्स आउट टू बी ई एंटीजन नेगेटिव, ALT नॉर्मल, असल में जो ई एंटीजन पॉजिटिव डिजीज है उसकी मदर टू चाइल्ड ट्रांसमिशन है 40 to 70%. इट इज अबाउट 20% इन ई एंटीजन नेगेटिव पेशेंट्स. तो फिर उस केस में जो गाइडलाइंस हैं ईजल की, वो तो ये कहती हैं कि अगर हाई वायरल लोड है, नॉर्मल ALT है, आप यू कैन ऑफर ट्रीटमेंट टू द मदर्स with the thought that this might prevent the baby from getting hepatitis B from them. तो ये है. अगर डॉक्टर असद, डॉक्टर फारूक कुछ ऐड करना चाहते हैं.
बुशरा, इसमें एक और जो बड़ा फैमिली का कंसर्न होता है, वो जब इस तरह IUD होती है या वो सारा कुछ बी पे डाल देते हैं, कहते हैं जी कि ये तो बी की वजह, उसको आप कैसे समझाती हैं?
यूजुअली तो हम नहीं देखते हेपेटाइटिस बी से
मैं बात कर रहा हूँ
तो
कि
हमने नहीं
बी
कभी
तो नहीं
देखी.
करता ना, लेकिन जो फैमिली
अच्छा.
है वो तो बेचारे जब डिस्कशन होती है तो वो बहुत सारी उसकी वालदा का या फुफ्फो का या किसी का ख्याल होता है ये बी की वजह से हुआ है. तो I mean, you know how you sort of calm them and
what I usually tell them is that that could have had several reasons and hepatitis B is not one of them. इसके अलावा उससे ज्यादा डिटेल में ज्यादा से ज्यादा मैं ये पूछ लेती हूँ कि हुआ क्या था, प्रेगनेंसी इंड्यूस्ड हाइपरटेंशन थी, कॉर्ड अराउंड द नेक तो नहीं थी, बस इतना. तो थोड़े से सवाल आज, लेकिन यू हैव टू एम्पथाइज एंड यू हैव टू शो कंसर्न. उसको ये तो नहीं किया जा सकता कि अच्छा IUD हुई थी, नाउ वी विल टेक इट फ्रॉम देयर. उसको थोड़ा सा एड्रेस करके एंड देन यू टेल देम दैट इट कुड हैव बीन एनी वन ऑफ दीज रीजंस एंड देन यू start counseling about the future.
जी, थैंक यू. इसमें बस एक चीज मैं और ऐड करूंगा, जिसने डॉक्टर बुशरा ने फैमिली का कहा. शी इज मैरिड एंड ऑलरेडी जस्ट वेंट थ्रू प्रेगनेंसी. हस्बैंड का बड़ा जरूरी है कि वेदर और नॉट ही वाज वैक्सीनेटेड. इसको तो 5 साल से पता था, लेकिन अगर अभी हस्बैंड का भी पता चला तो हस्बैंड के लैब्स और उसका वैक्सीनेशन स्टेटस और उसका anti-HB स्टेटस दोनों सूरतों में that becomes very important. ठीक है जी. फारूक, एनीथिंग आप ऐड करना चाहें इसमें?
नहीं.
Any question on this case? We have some 5-10 minutes. Uzair, if you can stop share. इससे ऑडियंस में कोई क्वेश्चन है? ये काफी कॉमन सिनारियो है ये, जो कि हम सब देख. जी डॉक्टर अनवर अली भुट्टा, आप कुछ कहना चाहेंगे?
नहीं सर, मैं सुन रहा हूँ. थैंक यू वेरी मच.
थैंक यू. थैंक्स. Any question?
बुशरा, इनकी अल्ट्रासाउंड की फाइंडिंग्स क्या आती हैं, अगर कोई आती हैं? आपने बिलियरी ट्रैक्ट देखना होता है तो क्या वो एक्चुअली डायलेटेड मिलता है?
और इसमें हेपेटाइटिस बी में
हाँ, वो आपने कहा ना अल्ट्रासाउंड देखना है, करना है। Consider कर रहे
अल्ट्रासाउंड
थे ना ultrasound?
हेपेटाइटिस बी में सिरोसिस को डिफरेंशिएट करने के लिए है ना?
अच्छा,
अच्छा, आप मेरा ख्याल
वैसे
डॉक्टर
कुछ,
नजम पूछ रहे हो
जी।
प्रेगनेंसी
प्रेगनेंसी
में
के
जो डॉक्टर बुशरा
लिवर की फाइंडिंग पूछ रहे हैं।
हाँ जी 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 जी,
अच्छा, वो आप लोग कहते हैं हाइपर एक्वाइक लिवर है।
उसका क्या मतलब है?
ये आप बताएंगे।
Probably it's
नहीं, मैं
because
वही
of the
कह रहा हूँ
high
कि मैं
vascularity of the liver. This is what my understanding is. Liver enlarge भी करता है pregnancy में, और उसकी vasculature भी dilate तो नहीं fair, लेकिन it becomes a hypervascular organ. So मेरा ये understanding है कि वो hyperechoic because of the increased blood circulation.
So Dr. Najam, मैं आपको बता दूं, we've been caught more than once to have a biliary duct dilatation due to gallstones in pregnant, particularly जो jaundice हो जाती है ना बीवियां. I think I agree with Dr. Bushra. Their ultrasound is paramount. I have been caught more than once in ladies with raised LFTs, abnormal ALK phos going up, and then 3-4 days later, उनको अच्छा इसमें in fact I would expect कि इन लोगों को पेन होनी चाहिए, पर actually पेन फैक्टर इतना ज्यादा नहीं होता इसमें. So I agree with Dr. Bushra. This is our standard practice as well. Kings maybe if you have a lady whose LFTs are going up, particularly if she's jaundiced, we'll just get an ultrasound scan with no second thought. Female 40, fat, pregnant, you know that 4 Fs. We've caught so many times that a non-invasive ultrasound scan is of no harm. And then, of course, doing ERCP is a different, very, very different. It's out of the scope of today's talk in pregnancy, but I think it's very useful test to have.
Fair enough. Thank you.
सदब हमें छुट्टी दे दो यार.
जी जी, आपको छुट्टी दे दें. किरण आपको भी छुट्टी दे दें. If there is no other question, I think I would like to thank everybody. As you can see, Abdullah Shimshad here, Dr. Khaja Parvez, Dr. Nadia. Dr. Najam, ये एक सवाल है मेरे ख्याल में. Let me. Hyperechoic liver means liver parenchymal echogenicity is increased, and radiologist compares the echogenicity of liver with right kidney. ये डॉक्टर नादिया की तरफ से सवाल है. If you can quickly answer, Dr. Najam.
I agree with the statement कि basically जो reference points हैं वो kidneys हैं on either side. तो spleen के साथ left kidney and liver के साथ right kidney. अब hyperechogenic kidney जब liver हो जाता है, interestingly the kidney gets blacker, जो cortex है उसका. So वो जो comparison है, it actually falls apart. Then it becomes much more subjective. Like in initial phases के अंदर, when it's subtle, then you only have the renal cortex to compare with. Of hyperechogenic, most of the time, well, in fact, majority of the time, yes, I would think of fat infiltration. I would not think of congested inflammatory liver parenchyma. Then I would want to compare right lobe with left lobe and also do segmental assessments. कोई ऐसा तो नहीं है कि जहाँ पे normal parenchyma नजर आ रहा है, patchy fatty infiltration is well known. अब जब हम बात करें pregnancy की, that's the reason I asked the question कि हम से फारूक ने rightly बताया कि they can have silent stones, but they can be causing obstruction. साथ में pancreatitis भी हो सकता है. So the story goes on. लेकिन हमारे पास जो references हैं वो स्पेयर्ड एरियाज भी नजर आने शुरू हो जाते हैं. सो गॉल ब्लैडर में स्पेयर एरिया जो है वो रेफरेंस बन जाता है. फिर देन द किडनी इज आउट एंड जब सारा कुछ होमोजेनसली ऊपर चला जाए, वाइट वॉश हो जाए, एंड वी कांट सी द पोर्टल सिस्टम, वी कांट सी द हेपेटिक वीनस सिस्टम, वो तो डेफिनेटली फिर हम फैट की तरफ ही जाते हैं. फिर देन वी डू नॉट कंसीडर simple congestion or anything else. But I agree with the statement which was made. The right renal cortex remains the basic comparison in majority of the parenchymal hepatic diseases.
Thank you. Thank you very much, Dr. Najam. Truly exciting session today. Ji Kiran, over to you.
Thank you very much, Dr. Bushra, Dr. Najam, Dr. Farooq. और वी फाइंड कि जब भी केस बेस्ड डिस्कशन होती है तो सेशंस काफी इंटरेक्टिव होते हैं. इसी वजह से वी डू इनकरेज कि अगर पार्टिसिपेंट्स अपने केस हमें भेजें, वी हैव द फॉर्मेट आपके साथ शेयर किया जा सकता है और आपके केस हम खुद भी प्रेजेंट कर सकते हैं. तो आइंदा के लिए भी आप लोगों से है गुजारिश कि आप अपने केसेस हम तक पहुंचाने की कोशिश करें. और वी आर ग्रेटफुल एंड थैंकफुल टू पाकिस्तान सोसाइटी ऑफ हेपेटोलॉजी एंड फेरोसेंस लेबोरेटरीज लिमिटेड फॉर अनरिस्ट्रिक्टेड एजुकेशनल ग्रांट. और इसके अलावा हमारी टीम एट पारसा ट्रस्ट एंड पारसा एको पाकिस्तान. अल्लाह हाफिज. उज़ैर, यू कैन प्लीज कॉल ऑफ द सेशन. थैंक यू.
Good night. Thank you.
Hafiz.